Hello, hello. How's everyone doing? Doing okay? Doing okay? All right. My name is Aslam Sayed. You guys are all here to see me, I hope. All right. So, majority of the talk today is going to be basically colorectal cancer screening. Okay. As a lot of you may be aware or not, March, which is now done, but they were courtesy enough to give me a slot in April. March was Colorectal Cancer Awareness Month. Okay. So we try to encourage colorectal cancer screening, and I'm going to go through that for the bulk of the presentation today. All right. How many of you have had some type of colonoscopy? Good, good. Oh, almost. Lots of fields. Okay. All right. So gastroenterologist and hepatologist, that's what I was just talking to her about. I do essentially everything that encompasses anything from what you eat to what you poop. All those organs are mine, all right? And everything in between really too, okay? So what I mean by that is liver, pancreas, gallbladder. I'm not technically a surgeon. I do minimally invasive procedures like endoscopies, but I do all medical management for some of those organs as well, all right? So just a little background about myself. I don't know how many of you have already had appointments with me, if not, but I'm Cleveland born and raised. I'm an Ohio native, so a lot of you are probably can say the same. But I did all my training essentially up in Cleveland at Metro Health Medical Center, part of the Case Western facility. I was actually born in that hospital as well, so that's a fun fact always. I did a couple years of research. I will go through one of my papers today. I have over 100 publication references in the course of my 2-3 years of research fellowship. A lot of them are easily searchable on Google if you guys like to read about research and data and things like that. Then I went ahead, moved forward with my research fellowship and did clinical fellowship in Pittsburgh. Boo Steelers, but for the most part. But so that was a quick 3 years where I took my exam, my 10-hour exam to be board certified in gastroenterology and hepatology. And then I started here in October. Yeah. All right. So what do I do? Very brief introduction. We're going to get into the colon stuff here briefly. But like I said, a little bit of everything what you see up here. This is not a comprehensive list, but probably the more common things we see in the office. Okay. So esophagus, which is your food pipe. That's where everything gets swallowed and, the first step of digestion. So common things, of course, a lot of you, I'm sure, have heard of things like reflux. Dysphagia is a fancy way of saying trouble swallowing. Okay, there's dysphagia, there's odonophagia, which is pain when swallowing, difficulty swallowing. All those should technically be evaluated as well. Hiatal hernia, relatively common diagnosis, which is a little pouch that a lot of people develop. Nothing you really do to prevent that. Sometimes requires surgery. Esophagitis is inflammation of the esophagus. Moving on into the next portion where all the food drops in the stomach. Ulcers, I manage gastroparesis, which is a fancy way of saying that your stomach doesn't digest as well as it should. A normal time of food in your stomach is about 3 to 4 hours, give or take. And when it prolongs that 3 to 4 hours, on occasion we call that gastroparesis. The most common diagnosis of that is people with poorly controlled diabetes, medication sometimes, narcotics, can cause that as well. So I manage that. Gastritis is a fancy way of saying inflammation of your belly. Then moving on to the colon, irritable bowel syndrome, relatively common diagnosis. IBD is short for inflammatory bowel disease, which encompasses something called Crohn's, either Crohn's disease, Crohn's ileitis of the small bowel, which is your small intestine, Crohn's colitis, which is Crohn's of your colon. All right. The other brother of that disease, they kind of fall in the same category of IBD as ulcerative colitis, which I manage as well. Polyps, of course, which we'll talk about that, so I'll skip over that. And then colorectal cancer. Yes, I diagnose them. I don't technically manage it. I put that in the hands of either a surgeon or an oncologist, which is a cancer doctor at that point, but I would be the first step in that. Liver, pancreas, relatively comprehensive, viral infections, liver infections, fatty liver disease, which is relatively common, cirrhosis, which is considered end-stage liver disease, either from things like hepatitis, infections. Hepatitis is not only hepatitis C. Hepatitis is just a generic term that means inflammation of the liver, all right? So high LFTs, LFTs is short for liver function tests. So those are numbers that a lot of your PCPs might be checking on occasion, and then they send you my way if those numbers are elevated. Okay, all right. All right, so what do you expect when you see someone like me? I'm considered a specialist, not just primary care. So essentially a referral is placed, or sometimes a self-referral, depending on the situation. Initial clinic visit, 90+% of the time. There's rare scenarios, patients go straight to procedures, depends on the physician preference. But more often than not, I see you in the clinic right here, okay? And we talk and see what we can do for you, okay? So the next step is medical management and or endoscopic evaluation. Two broad categories, okay? Obviously, if you've already had recent scopes, I may not need to do them again by my colleagues and or partners, either in Columbus or here. And then medical management, that's, of course, as it sounds, medications if you need it, okay? And then follow-up, I almost follow everyone up after endoscopic evaluations. There's rare circumstances where I may not need to. If you are 45 and you had a normal colonoscopy and you're not due for another 10 years, then you probably don't need to see me in the clinic at that point. You can always save your time and see me if necessary. Okay. Pretty common, unfortunately, in this country, and the prevalence is on the rise. And I'll explain that as well. But third most common cancer in the U.S. in both men and women, and as second leading cause of cancer-related deaths. Okay. So unfortunately, it's pretty high up there. For women, of course, as long as you know, it's probably breast. Prostate's up there for men. The lung cancer is pretty high up there as well. But colon cancer is pretty common in this country, right? In 2025, give or take, we're expecting over 150,000 cases to be diagnosed nationwide, of course, not just here, and 52,000 expected deaths. And those are pretty common numbers. They haven't changed a whole lot in the past decade or so. They've stayed relatively consistent. If anything, these numbers are actually better because of all the advances that we have now. Early detection, early diagnosis, removal of polyps, all these things have actually decreased these numbers. So these numbers are actually continuing to improve. All right. Risk factors. So what I mean by risk factors is the topic of our conversation. So these are risk factors for colon cancer, okay? So colorectal cancer and or colon cancer for short. A lot of people leave out the rectal part. It's kind of in the same realm, same organ, so we don't always call it colorectal cancer, just FYI. I'll use both terms synonymously. So overweight, big problem in this country, as I'm sure many of you know, kind of a obesity pandemic in this country for the last decade. Metabolic syndrome, I explain this relatively often. It's in the wheelhouse of what I do, but metabolic syndrome essentially encompasses a few different diseases all into one state. And metabolic syndrome increases your chances of colorectal cancer. So what is metabolic syndrome? It's a combination of high blood pressure, high cholesterol, obesity, and diabetes. Okay. More papers, more research out there essentially shows that if you have about 2 of those, you're considered to be somewhat at a higher risk of metabolic syndrome, all right? Smoking, alcohol, family history is a big one, okay? That's why we always ask at every appointment. First degree relatives, okay? I'm gonna talk a little bit about that in detail because it can be confusing, but essentially a first degree relative with colorectal cancer does increase your chance. IBD increases your chance, specifically ulcerative colitis, like we talked about, ulcerative colitis and Crohn's. Crohn's to a lesser extent, but we survey and do colonoscopies in patients with IBD relatively often, sometimes even yearly, okay? Poor diet, processed meats, things like that can increase your chance ever so slightly as well. That's our national organization. They did a whole campaign in about 2020, give or take. So we have been encouraging for about the last 4 or 5 years now to start screenings at age 45. So this was one of their big campaigns that they did at the time, where 45 is the new 50 for screening and prevention. All right, so what are some common symptoms? I should have probably put asymptomatic up higher, but it was an afterthought because you don't think about it too often. But asymptomatic is actually the number 1 symptom, okay? You don't know you have it, okay? So you're 45, you think you're Superman or whatever, and you don't think too much about it, all right? But it can be one of those silent things, all right? So age 45, you never had a colonoscopy regardless of family, a good idea to get some type of screening, and I'll go through some of the different modalities for that. Okay, other more common symptoms which should move forward with a diagnostic colonoscopy, and I'll explain some of these terms. Rectal bleeding, as we talked about, unexpected changes in your stool, all of a sudden it's thin or lumpy, or all of a sudden you're not pooping for 4 days when you were doing okay before. These are changes in acute changes in bowel habits. Rectal pain, unintentional weight loss, which no one ever tells me they have, and unexplained anemia, okay? Anemia meaning is low blood counts, all right? So your PCP may check some routine blood work and say, why is your hemoglobin so low, all right? Now, if you're a 40-year-old, 45-year-old female and you're getting a CBC, just be aware that your hemoglobin can be a little low from your natural menses. But if this is significantly low, or if it's low in a male, that should prompt investigation, okay? This slide was from American College of Gastroenterology during their campaign. Colonoscopy, gold standard. I don't think, no one can argue that, okay? PCPs can't argue that, we can't argue that, no one can argue that. It's the best test for your initial colorectal cancer screening, okay? I always am trying to promote colonoscopy in anyone that has one. If they really don't want to have one and they're average risk, which I'll explain in the next couple slides, then they can get away with stool testing, okay? There's a couple different stool tests. Some of you probably have heard of them. There's Cologuard, there's FIT, and there's a fecal occult testing and things like that. The punchline is that, and if any of those tests are positive, you end up with a colonoscopy anyways to see why it was positive, if there's a reason for it. There are false positives, there are false negatives, so just be aware. Whereas a colonoscopy, you got 4, if not 6 eyes on the screen at any given time, obviously my eyes included, while I do the procedure, as well as my tech, my RN sometimes is watching, sometimes even my CRNA is watching. So you got multiple people looking at the screen all at once, assisting me to make sure I'm not missing anything, which is obviously the gold standard test, okay? All right, average risk, okay? So these are the only people that should be getting stool tests, okay? This is one of the pet peeves of mine because PCPs will sometimes order some tests and then they'll come to me for a positive Cologuard, as you know, and then like 3 of the relatives has colon cancer. I'm like, you shouldn't have gotten a Cologuard in the first place, okay? Or they come to me and say they've been having blood in their stool, you know, twice a month. They should not be getting Cologuards, okay? Cologuards, those boxes, those commercials you see, the fecal immunochemical test, FIT for short, those are for asymptomatic, average risk individuals only, okay? All right, now if there's questions, I'm happy to answer. So who are those population? No family history, first-degree relatives. Now, if like your third cousin had colon cancer, that doesn't count, okay? So a first-degree relative with colon cancer, a personal history of precancerous polyps. I see this often too, and I scratch my head about it because it's like someone will come to me and say, oh, they had polyps 3 years ago, but then someone decided to order a Cologuard on them. That doesn't make any sense. If you've had previous history of polyps, you should be getting, you have earned the right for colonoscopies for the rest of your life, okay? No symptoms, of course, all right? So weight loss, bleeding, pain even sometimes, okay? Colitis, of course, of any kind, either on a CAT scan or a personal history. Again, those patients should not be getting any type of stool testing, okay? A nice, boring 45-year-old that has 0 issues can get away with it, okay? Other than that, you should be getting some type of colonoscopy, all right? Different terms I use, not only for documentation purposes, but for you guys. Average risk, we kind of already went through. Those are your boring, no history, no symptoms patients that come to us just for standard. A lot of those patients are now going through express endo, I think. So they go straight to colonoscopy if they have no issues, okay? High risk colonoscopy, essentially all it means, it's a little bit of a misnomer, but essentially means that you have a first-degree relative with colon cancer, so it increases your own risk of having colorectal cancer, all right? Surveillance colonoscopy is you survey. 5 years ago, you had polyps. Well, the term surveillance colonoscopy is then used moving forward because now we have to survey for more polyps, okay? It's not your index colonoscopy, meaning your first one, all right? Diagnostic colonoscopy, that term I typically reserve for people under 45, under 50 that have symptoms, okay? 25-year-old with bleeding, if you remember what I said earlier in the presentation today, I'm going to do a colonoscopy in that patient until proven otherwise that it's not coming from anything bad. Okay, that's considered a diagnostic colonoscopy. All right. Family history. Okay, this can get confusing for a lot of patients and public out there. It's really only first degree relatives. Okay, mom, dad, brothers, sisters, kids. Okay. Your second cousin, your maternal uncle, or your whatever doesn't really count, okay? And I say that with a little bit of hesitation because if like 4 of them, distant relatives, have colorectal cancer, then we got to start wondering about what the heck is going on, okay? So kind of at that point, I would love to know, but at the same time, it's primarily a first-degree relative, okay? How do I prepare? You get instructions. Everything is mailed to you and or given to you in a folder, in a packet. Essentially, there will be pre-colonoscopy. This is what I'm referring to. There'll be some diet modifications. Of course, the delicious prep that I prescribe at your local pharmacy. Med holds may need some approval. That essentially comes down to blood thinning medications. Anything that thins your blood is going to have to be held in case I have to remove polyps. I don't want a bloody mess in there, all right? Cleaner the colon, the better the outcome, okay? Really got to follow those instructions, okay? You're doing your own justice to your own self, okay? Meaning the better your colon gets cleaned out, the better I'm going to be able to do what I do for a living, all right? You'll need a responsible party for the full day, and that's per anesthesia guidelines more so than me, because you go to sleep and the anesthesia can make you feel woozy, you might fall, you can't drive, so it's always important to have someone, a loved one or whatever, with you for about a 24-hour period to make sure that none of those things happen. Okay. Expect to miss probably about a day of work. Okay, probably not more than that. The day of the procedure itself, you obviously won't be able to work because you'll be legally under the effect of anesthesia. All right. I do my procedures on Mondays and Wednesdays as of now. That hasn't changed as of now yet, but that's, pick your preference there, okay? Prep tips, okay? Obviously, probably most people can agree it's the worst part about the procedure. The day before, the prep, all right? I almost always do something called go lightly. That's how I was trained in my fellowship. That's what I practice with. That's what I'm used to. That's what I like. Now, if patients have a different formula they want, okay, like Sutabs, which is the pills, Suprep, which are the 2 tiny bottles, I listen and I prescribe whatever they want. But I like to do go lightly, okay? Couple of tips. I used to get these phone calls at 3 o'clock in the morning that they can't tolerate and things like that. And then I used to go through these tips with them to help kind of increase their chance of actually finishing the prep, okay? The colder it is, the better, okay? It masks the taste of it, lots of ice, keeping it in the fridge in between breaks, things like that. Sipping another clear liquid diet. Some people are under the impression you can only have the prep once you start it. That's absolutely not true. You can definitely break it up with other fluids if you'd like. Okay, it's more volume for you. I get that. It can make you more nauseous. Who wants to drink more than that already? But the taste can at least kind of break it up, okay? Other clear liquids, ginger ale, Sprite, Gatorade, whatever you'd like that day, all right? Some PCPs, and even myself, if you just can't do it, sometimes we'll give you 10 pills of Zofran, Phenergan, one of the anti-nausea medications to help get you through that day. And some may need longer. Constipated patients that don't prep well the first time. They have a history of poor preps in the past, okay? Sometimes those patients, unfortunately, are even worse because I have to sometimes do 2-day preps on those patients, okay? And I may go through that with some of my patients. I almost will never know that until I'm in there the first time. So, most of you guys are probably off the hook, okay? Colonoscopy, we obtain your history, risk factors, family history, etc. I figure out whether or not you're on any blood thinners or GLPs are the hottest kind of medication on the market right now. Those are your Wegovy's, your Ozempics, your Mounjaros, and things like that, the weight loss medications. They slow down everything in your body, including your colon, so people don't prep very well when they take those medications, and it increases your chance of aspiration as well, all right? Cardiac history, it's important to know that. Pacemakers, defibrillators, things that I may need to stop or temporarily put magnets on to stop those devices while I cut something out inside of your colon. What should you expect? I say ballpark, you're probably expecting about a 3-hour day, give or take. They're going to ask you to come in 1 hour before to do all their pre-op and all that good stuff. And then my procedure itself honestly takes anywhere between 20 and 30 minutes. It's not a long procedure, depending on what I see in there, of course. Now, if you're a polyp farm, it could take a lot longer because I have to sit there and remove a lot of those. Okay, but I would say average time is about 30 minutes. Okay. Post-procedure, that you recover, they give you something to drink, they get you dressed. That takes about 20, 30 minutes. They check your blood pressure every few minutes to make sure the anesthesia hasn't bottomed you out, and you go home, okay? So about 3 hours, give or take, for the whole day, all right? You can go back to all normal activities the next day. Not a full video, but a lot of you did raise your hands already about having one, so that's nice to see. But essentially, your colon is a big tube. I navigate through it like a video game, and I look for these little guys, which are called polyps. I look for colitis. I look for cancers, of course. I look for anything that may need addressing. Okay, polyps obviously is the most common finding. That's essentially why we do these. And here's just a quick snapshot of someone that doesn't look like this. This is computer generated, but someone removing a polyp with something called a snare. All right. What are the risks? Okay, I go through this in my appointments in clinic, and then we go through it again before signing the consent. Less than 1% really of any of these things. So, sigh of relief a little bit. Yes, it can happen, but it's very rare. 99.99% of the time, it's a very safe, well-tolerated procedure. We typically quote less than 1%, maybe 1.5% chance of complications. Okay, those include bleeding. If I see a big polyp and I remove it, there could be blood loss. Perforation is basically a hole in the colon, a really, really large polyp that I'm removing, and ends up removing part of your colon itself, and now you got a little hole there. Okay, once in a blue moon, I can clip those shut. Once in a while, I need surgical assistance. All right, infections. We're introducing a 3-foot foreign object into your body. Okay, it is not sterile. All right, the procedure is not sterile, but your colon is not sterile. All right, it's full of poop. Okay, so your poop is not sterile. Right, so it doesn't have to be a sterile procedure. Okay, so I've never really dealt with that. It's not a common scenario whatsoever in terms of infection. Anesthesia itself has its own risk, of course. Sedation, sleeping, not waking up. Getting tubed, ventilators, okay, again, extremely, extremely rare, and then surgery, okay. Let's say I find something that I can't do, but it needs to be done. That could include a cancer, a polyp that's too large, but needs to come out, or there's bleeding too much, or there's a perforation. Once in a while, they may require surgery, okay. All right. Discharge, you go home, same day. Diet, everything diet related is fair game the same day. The only restrictions that they may tell you in post-op are things like driving, big decisions, don't sign your life away, wills, stuff like that, because of the effect of anesthesia, okay? And then the next day, 90+% of people go back to a completely normal life. Basic terminology, everyone gets sent home with discharge paperwork and my pictures, okay? I like to take lots of pictures, and you'll get a copy of all of those, right? Polyps included, what I did, what I didn't do, et cetera, et cetera. So this covers probably about 90% of the terminology I use, this slide alone. Different parts of your colon, all right? I'll use these terms: sigmoid colon, descending colon, transverse colon, ascending colon, and cecum, all right? Cecum, you're at the end of the colon. I always take a picture of that, all right? To prove that I got to the end of your colon and that I examined your entire colon. So diverticulitis is an infection, okay? So that's why people say, I have a history of diverticulitis. No, you don't. You have a history of diverticulosis on your colonoscopy 10 years ago, okay, which is normal. Doesn't change screening, don't have to do earlier colonoscopies for it, okay? Diverticulitis is diagnosed by CAT scan, and only such, okay? Pain, fevers, chills, sweats, diaphoresis, clammy, significant amount of pain, changes in your bowel habits, sometimes blood, sometimes not, diarrhea, sometimes not, okay? These things, a lot more often than not, they go to the emergency room, they do a CAT scan, they find that one of these pouches is now infected, okay, because something got stuck in it, something happened to it, whatever, okay? The reason it's important is because I need to know if you've had diverticulitis by CT, because I follow those cases up with a colonoscopy, okay? And why do I do that? To make sure that the infected diverticuli was not infected by a cancer, okay? That there wasn't a growth inside one of these that led to the diverticulitis. So I let it resolve because it increases your chance of a hole in the colon. So I usually do about 6 to 8 weeks after the resolution of that episode. Okay.
So it's curable?
Diverticulitis, yeah, it's just an infection. Just like, think of it as pneumonia. You take an antibiotic. ED almost sends probably about 80% of their patients, they probably send home right then and there with the course of antibiotics, okay? About 20% of those patients that do not tolerate oral antibiotics, they can't tolerate any nutrition, they need to be admitted for hydration, IV fluids, IV antibiotics sometimes, okay? There's complicated diverticulitis, there's uncomplicated diverticulitis. I can probably give a whole lecture on diverticulitis alone, okay? But essentially, to answer your question, it is extremely curable. It's an infection that you give an antibiotic for. 80% of colorectal cancers come from polyps. Hence why we screen patients so rigorously, okay? This is why we do colonoscopies, because majority of cancers come from polyps that were not addressed when you were 45, when you were 50, when you were 55, when you were 60, okay? But majority of them never turn into cancer, okay? But we take them out, of course, all right? Less than 1% of adenomas develop into cancers, okay? Now that changes. A huge one, okay, a 4-centimeter one is going to have a much, much higher likelihood of turning into cancer than a 4-millimeter one, all right? So size comes into play there, all right? And approximately 10% of polyps, especially the precancerous ones, over 1 centimeter, now we went from 1% to 10%, all within when they're well over 1 centimeter, okay? So you can see that it exponentially increases your chance of developing colorectal cancer the bigger the polyps are, all right? A lot of people just wonder about when my next one is, and that's my job. I do that for you guys. Generically speaking, polyps, precancerous, it's almost always somewhere between 5 to 7 years, okay? The more you have, the less that time gets, okay? Cancers yearly, okay? That's why it says 1 year over here for over 10 precancerous polyps, okay? Because your chance is going to be higher. If you have a normal colonoscopy, or HP stands for hyperplastic, 10 years, okay? And then it kind of goes down, all right? Couple tiny little guys, less than 10 millimeters. I usually err on the side of caution, so I say 7. I almost never give them 10, all right? SSPs, sensory serrated polyps, some controversy there, but I typically say 5 years for those as well. And then the more adenomas you have, the more precancerous polyps you have, the less your interval gets, okay? So 3 years, et cetera, et cetera, et cetera, et cetera, 5 years, 7 years, and then we call you for that explanation, all right? What can you do? Be healthy. I mean, generic. Physically active has been shown, number one, in all reports out there, literature has shown that the more active you are, the less you are to prone any type of colon cancer, all right? Alcohol, tobacco, the common stuff, all right? Don't poison your body, essentially. High fiber diets, all right? That's where fresh fruits and vegetables come in, of course, for gut health, all right? Makes you poop better. Limiting processed things, and getting checked, of course, and getting your questions answered by someone like a health professional, all right? Primary care, myself, whoever. Good? Of course, guys. Thanks for coming.